have several other resources that will teach you how to do a systematic review and meta-analysis properly. But first, let's ask a couple of questions about why we should do systematic review and meta-analysis, or when we should do systematic review and meta-analysis. First is when you have multiple studies trying to answer the same question. For example, is drug X useful in condition Y? And you might have 5 trials testing the same question. So you might want to know what is the benefit overall, because some trial may be saying the benefit is 8%, the other trial is saying 10%, the other trial is saying 15%. So in such conditions, you'll need to meta-analyze to get the synthesized answer. The other is when you have conflicting results from studies. One study might say this intervention is helpful, the other study might say this intervention is not helpful. So is it helpful? In that case, you should do a meta-analysis. And other personal reasons. Meta-analyses are highly cited. So compared to your case report, which might get 0 citations in 10 years, a meta-analysis is more likely to be cited. So that is good for your career, especially when you are early. And comparatively, it needs less amount of training than it needs compared to, if you want to do a bench research, if you want to become a microbiologist, or even other types of research, it needs more training. Systematic reviews and meta-analysis require relatively less training, but it's a question mark because you have to do it well. But a couple of risks. One is the risk of being scooped. Because it is easy to do, there are several people doing it. In fact, China seems like a factory of meta-analysis nowadays. As a peer reviewer and editor, I have experienced like thousands of meta-analysis coming from China, and it's so hard to see whether it is properly done or not, or sometimes even the question is relevant or not. But to be just to caution you, if you think something is important, there might be some other people already trying to answer that with a meta-analysis. And then there is the problem of GIGO, garbage in, garbage out. Because a systematic review will help you to synthesize studies. It does not improve the quality of the studies. So if the studies that you are including in the reviews are garbage to begin with, your synthesized answer will be garbage. What does one garbage plus second garbage make? Garbage. It does not improve the quality of the evidence. But a few clarifications, I think, are important. As I mentioned, I just want to focus on certain principles of systematic review and meta-analysis. For training, please follow those resources that I mentioned. So the first thing is, when we say systematic review, the search part is systematic. What does systematic mean? It means, if someone is asking you, is metformin useful for pancreatic cancer? Then you might know a couple of studies about that, but that's just your memory. Or you might read a book about it, but that book might have cited only those studies that fulfill the agenda. So the search part should be systematic for it to be called a systematic study. So that means you need to have a specific criteria to search for all possible studies trying to answer that question, and it should be replicable, so that if someone gets your search strategy and runs the same test, they will come up with the same set of studies. So this skill is important. If you know how to do a systematic search, you can use that skill to answer any type of question. It always does not have to be a systematic review and meta-analysis. For example, I have written commentaries using systematic search. This was a commentary that I wrote about what were the endpoints that were being used for trials of COVID-19. And as I mentioned here, we did a systematic search using certain keywords. So those systematic search skill is what is important. The final product may be a commentary, it could be a letter to editor, it could be any variety of publication. And systematic review means qualitative summary. When you are trying to synthesize the results and you are giving a qualitative summary, that is systematic review. If you are giving a quantitative output, that's a meta-analysis. For example, we wrote this paper about cheaper options in the prevention of chemotherapy-induced nausea and vomiting in Journal of Global Oncology. And we did a systematic search. The search part is systematic. We wanted to find all possible cheaper options that were available for chemo-induced nausea and vomiting, but there is nothing to come up with a number there. There is no meta-analysis here. So it's just a systematic review and not a meta-analysis. Meta-analysis means quantitative summary, so that will need statistical intervention. In systematic review, there is no statistics involved. And therefore, not all systematic reviews end up with a meta-analysis. Because you performed a systematic search, you came up with 10 or 12 studies, and you found that it made no sense to combine the results. So you just publish the results descriptively. That is systematic review. If you are able to combine the results, then that is meta-analysis. For example, this systematic review that I was a part of for primary febrile neutropenia prophylaxis in patients with breast cancer receiving FEC and taxane chemotherapy, we mentioned in our methods about data analysis that if deemed appropriate after exploration of a study and patient characteristics, then we plan to perform meta-analysis. But when we came up with the included studies, it made no sense to do a meta-analysis, so we did just a systematic review. So we mentioned that in our methods. And the other clarification is the endpoint of the meta-analysis can be different from the endpoint of the included trials. For example, let's say eradication of Helicobacter pylori to prevent gastric cancer. This has been studied in several trials, whether eradicating H. pylori helps in reduction of the incidence of gastric cancer. But when I read one of those Korean studies, I saw that yes, it did significantly reduce the incidence of gastric cancer, but for some reason, the all-cause mortality hazard ratio seemed a little bit unacceptable. It was like 0.9, and the confidence interval went up to 1.4 or 5. So I was concerned, is there increase in overall mortality? Yes, we are reducing gastric cancer incidence, but are people dying? So I did a meta-analysis, and as I said, I published this as a letter to editor. Does H. pylori eradication therapy to prevent gastric cancer increase all-cause mortality? So there were like 6 studies. So as I mentioned, my endpoint for this meta-analysis is, does it increase overall mortality? The endpoint of the included studies was, does it reduce the incidence of gastric cancer? So your meta-analysis endpoint can be different from the endpoint of the included studies. And in fact, a meta-analysis can have multiple outcomes. You can compare different outcomes within the same meta-analysis. For example, this was a meta-analysis of optimal duration, shorter duration versus longer duration of adjuvant trastuzumab in early breast cancer, done by me and Sarojini Raula, who is also a Nepali oncologist working in Canada. So if you look at the results here, you see that we looked at not only overall survival, we also looked at disease-free survival. We also looked at what happens in terms of cardiac events, what happens for ER-positive patients, what happens for hormone-negative patients. So a meta-analysis does not necessarily need to have just one outcome. You can look at several outcomes. And a meta-analysis actually does not even need to be, new, as in you don't need to necessarily always answer a new question. Sometimes an old question that has already been answered might need to be updated because there are newer trials coming up, because there are newer data. And in fact, nowadays, there is the concept of a live or a living meta-analysis or systematic review, because new data are coming every day, and so you can't trust the results of an older meta-analysis that does not include this newer intervention. For example, BMJ is very good at this. BMJ publishes living systematic reviews, updated systematic reviews quite often. And when we had COVID-19 pandemic peak, we needed all this data to be updated almost live because there was so much new information coming every day. And a meta-analysis actually does not need to be too complex. So one question I frequently get asked is, how many studies should we have to do a meta-analysis? And I think that's a foolish question, because to do a meta-analysis, you should start with a systematic search, and then only you'll know how many studies there will be. How can you start from the beginning saying, okay, there are 5 studies, I'll do a meta-analysis. There are only 2, I'll not do a meta-analysis. Unless you do the systematic search part, you do not know that answer. So a meta-analysis can have any number of studies. It can be 50, it can be only 2. Yes, even just 2 studies are enough if the question is relevant. I'll give you an example. So, there were 2 studies testing the role of sunitinib as an adjuvant therapy for renal cell cancer. One was called the SOI study, the other one was called the S-track study. And as you can see here, if you look at the hazard ratio, for the SOI study it was 1.02, it showed no benefit. For the S-track study it was 0.76, which showed significant benefit. So as I mentioned earlier, conflicting results. Just two studies, but one said it is useful, the other said it is not. So we did a meta-analysis, and we published it in Annals of Oncology, which is a very good journal in oncology. So I'm trying to say that it is just a two-study meta-analysis, and it still got published in Annals of Oncology because it was a very relevant question to ask. So we did a meta-analysis, and as I mentioned, we looked at several outcomes. What happens to disease-free survival, what happens to overall survival, and relative risks of developing serious side effects, fatal side effects. And it does not always have to be PubMed based. It has to be comprehensive. As much as you can, you have to include PubMed, Embase, Google Scholar, Cochrane Review. But what I'm trying to say is the systematic search skill is important. You can use it for any database. For example, going back to that commentary example I gave, we did a systematic search on clinicaltrials.gov. We did not do it on PubMed. We did it on clinicaltrials.gov. So depending on what your question is, sometimes searching the registry might be important. So sometimes searching the published information might be important. I want to spend a few minutes speaking on heterogeneity. This is an important concept. Heterogeneity means whether the included studies are more or less similar, whether we can add the results. For example, if the studies are too dissimilar, if the studies are too different, then it may not be appropriate to combine the results. And this we can test while doing meta-analysis using some statistical tools like a Q-test, which comes with a p-value and tells you whether the heterogeneity is statistically significant or not. And then there is the I-score test. Just to give you an example, so you will see that at the end of the forest plot, here it mentions test for heterogeneity. Q is 52. This number, it actually does not matter much, but the p-value is less than 0.001. That means the heterogeneity is statistically significant. I-square, again, there is some debate what is the cutoff, but anything over 30%, probably the heterogeneity is substantial. And in contrast, in this meta-analysis, you see a Q-value of 4, and the p-value is 0.96, and I-square is 0. So there is no statistical heterogeneity here. But I think it's more important to think about clinical heterogeneity, because it might be statistically non-heterogeneous, but it could be clinically heterogeneous. The patient populations might be different. Your I-square might be 0, but some patients might be black patients from Africa, some patients might be white patients from Canada, and some patients might be Indian subcontinent patients, different age groups. So is it appropriate to combine those results to get a synthesized one answer? So it depends on the question. Whether do you think that ethnicity is relevant for the disease or not? So it is important to ask when not to do a meta-analysis. As we know, a good surgeon knows how to operate. So similarly, a good researcher knows how to do meta-analysis. A better researcher knows when to do meta-analysis. The best researcher knows when not to do a meta-analysis. For example, let's say Ram has 3,000 rupees, Sam ate 2 apples, Rita worked for 3 hours. What is the total? Does it make any sense? The answer is definitely not 3,005. You cannot combine them. The same is true for meta-analysis, but this has been done. Look at this. It says a meta-analysis of the impact of a drug on survival of patients with advanced solid tumors. That means every solid tumor is combined. They are trying to see whether a drug is useful in gastric cancer, breast cancer, glioblastoma. Like, what's the point of combining all those cancers and saying this drug is useful or not? It might be useful in one cancer. It might not be useful in other cancer. This is a stupid meta-analysis. You should not be doing this. The other one, the role of targeted agents in adjuvant treatment of colon cancer. Why is this stupid? Because we know that individual trials testing this are negative. Individual trials are negative. There are 3 trials testing bevacizumab as an adjuvant therapy for colorectal cancer. All of them are negative. And do you think combining them will give you a positive result? No, you already know the answer. It is useless. So there is no point in combining the 3 trials and saying it is useless. Similarly, if there are 5 trials and all of them are positive, the combination will be positive. There is no point in combining them. In fact, I was so frustrated with this trend that I wrote in Lancet Oncology, meta-analysis and RCTs in oncology, what is the right balance? And I'll give you an example here. It's a pretty small font, but what I'm trying to show here is there are 3 RCTs of adjuvant VEGF inhibitor in renal cell cancer. There are only 3 RCTs, but there were 11 meta-analyses testing the same question. It's so redundant when the number of meta-analysis is more than the number of trials you have asking the same question. So we should know when not to do a meta-analysis. So just to give you a few real-life examples of what to write in a meta-analysis, how to do a meta-analysis, I want to share some of the meta-analysis that I published. For example, in JAMA Open, we published this meta-analysis looking at the relation between PFS and OS. So, in the method section, that is where it is most important. So first you talk about study identification. How did you identify the study? What are the databases that you used? And what are the search terms you used? Whether there was any timeline restrictions, whether you searched from this date to that date, and whether you looked at studies only published in English, or you looked at all the languages. Again, these things are important based on what are the answers that you are looking for. And then what were the exclusion criteria? For example, for this study, it made no sense to include non-randomized trials. So we included only randomized trials. We excluded non-RCTs. Blah, blah, blah. But you should think about what will the inclusion criteria be, what will the exclusion criteria be, and you should be very specific about it. And similarly, data extraction and methodological quality assessment. So you should speak about how the data was extracted. It is ideal for the data to be extracted by at least 2 people so that there is no mistake, like human error. And if 2 people are comparing the data, there are lesser chances of human error. And how did you resolve if there were discrepancies? And what was the end point of your meta-analysis? And then most of the meta-analysis, they come with a forest plot. This is called a forest plot, which compares the effect sizes across the trials and then gives you the overall effect size value. Another example, this was published in Annals of Oncology, risks of serious and fatal adverse events with sorafenib in patients with solid cancer. And these are the forest plots that I showed you earlier. So the things to look out here would be, I'll be talking about this random thing written here. Okay, let me speak about it right now. So as you can see, it says random here. And in the other one, it says fixed here. So there are 2 techniques of combining the data. One is called fixed effect meta-analysis, and the other is called random effect meta-analysis. So fixed effect is when there is less heterogeneity. When you are not worried about the heterogeneity between the studies, then you can combine them using fixed effects meta-analysis. When you think that the heterogeneity is substantial, then you have to use random effects meta-analysis. But I think as a rule of thumb, it's always safe to go with random. It's always safe to assume that, yes, the trials are heterogeneous. Because if they are not, the results of fixed effect and random effects will turn out to be the same. So you'll not be getting different answers there. But if it is heterogeneous, then the results will be different. And you might get a misleading summary by using fixed effect meta-analysis. And this is another meta-analysis that I did with one of the undergraduate students at Queen's. So this is just to give you an example that it does not have to be complex. As you can see, there are just 2 authors. One is a Bachelor of Health Sciences student, and the other is me. So if the question is important, and if you have the skills, which is easy to learn, then it does not have to be a big complex thing. So what I'm trying to show from this example is you can do it in Nepal. So some tips. So before you start doing meta-analysis, the question is, does this question excite you? And how do you answer that question? Think about what the news will be when those results are out. Does it make headline news? Like, it does not have to make news, but just to think about whether the question is important and does it excite you or not. Better not to synthesize than to synthesize improperly. So learn when not to synthesize the studies. If possible, register the study And you can register in this website called Prospero. This is a place where you can register your meta-analysis before you do it. You can register your protocol, and you can also search there to see if someone else has already thought about doing your study and you getting scooped. And use Prisma Guidelines. These are the standard recommended guidelines that you should follow while doing systematic review and meta-analysis. The Prisma diagram will look something like this. So always remember to keep a track of how many studies you excluded for what reasons, because you will be needing that at the end. And there are several tools available. You can use the Covidence software, you can use the RevMan software, I think RevMan should be free. And then about the statistical software, there are several options. This comprehensive meta-analysis is a commercial software. You have to pay for that. But RevMan is, I think, free, and it is very appropriate to use. It's made by Cochrane. Then if you are using other statistical softwares like Stata, SAS, R for other research, then you can use the same software to do a meta-analysis as well. But SPSS, I think, does not allow you to do meta-analysis. And as I mentioned, random effects model is always a safe option. And find a good systematic review or meta-analysis in your field of choice, and just try to model that structure, how they have written it, how they have summarized the results. Good luck.